Welcome to MLT 101. My name is H1 Barnes, and our topic is specimen processing. We're going to be going over terminology, specimen handling, and the delivery and processing of specimens. To start our terminology trip with, an aerosol is a fine mist of a specimen. You cannot always see an aerosol. They are frequently invisible to the eye. An aliquot is a portion of a specimen that is separated from the main tube that is used for testing. Central processing is a screening and prioritizing area where specimens are received by the laboratory team and prepared to be tested by another section of the laboratory. A centrifuge is one of the workhorses of the lab. It is the instrument that's going to spin blood tubes at a high number of revolutions per minute to create centrifugal force, which will cause the blood tubes to rapidly separate out from their liquid components and their formed elements. Pre-analytical means what happens before the sample is analyzed. QNS, the acronym QNS, stands for quantity not sufficient. That means you don't have enough sample to do the work that you need to do. TAT stands for turnaround time. Turnaround time is important, but not at the sake of quality results. It is, however, one of the biggest issues that is going to be pushed in the lab is to maintain turnaround time. The quality of your results is going to depend on correct procedures being followed during the 3 phases of the lab process. Your pre-analytical phase, pre meaning before, so that's everything that happens before you test and analyze that sample. The analytical phase, which is what happens as you are testing and analyzing that sample. And the post-analytical phase, which is everything that happens after you test that sample. Your pre-analytical phase is your most important phase. Even more important than doing the right test is making sure that you have the right sample from the right person. Because if you do your testing flawlessly, perfectly, but you test the wrong person's blood and report it out, you could kill someone. Identifying properly that you have the right patient and the right sample to do the work with is the most critical step in the entire laboratory process. Everything else can be done flawlessly, and it doesn't matter. Because if the pre-analytical phase isn't perfect, everything was a potentially dangerous waste of time. Your pre-analytical phase begins when your patient is assessed into the laboratory and a test is ordered. It's where the majority of lab errors are going to occur. Improper handling or processing is a pre-analytical error that can affect the analyte, and the analyte is the thing that you are analyzing, and cause an invalid or misleading test result, or delays or incorrect patient care because of that invalid or misleading test result. Specimen handling is going to begin when your test is ordered by the provider, which can be a physician, physician's assistant, nurse practitioner. It depends on who works at the facility you're at. Those are the 3 that you're usually going to see. And will continue throughout the testing process until results are reported out. Storage after testing is typically considered part of your post-analytical phase because you're done testing the sample, you put it in storage. However, it has the potential to become part of the pre-analytical phase again if the physician calls back down to the lab and says, hey, I saw these results. I would like to order another test. Do you still have that tube there, or do I need to send the patient back? If you've still got the tube in storage, that physician can then place another test order on that tube, and you pull it out of storage. So now storage has become part of the pre-analytical phase for this new test. Some of the possible errors that you might see before collection are an inadequately prepared patient. Either they're dehydrated, so it's hard to find their veins, or they're not fasting. They could be on different treatments like an intravenous medication or radioisotopes. The physician could have put in the wrong test, or they might not have ordered every test that they wanted. Oftentimes, the physician themselves isn't always the person who's actually placing the test orders. They will tell an assistant what lab orders they want to have placed, and that physician or that physician's assistant, not always a PA, but the person assisting them, will go in and create the orders in the computer ordering system. Sometimes things are lost in that process as the physician tells that person who's assisting them what needs to be ordered. So you may have an incomplete order, and the doctor will call down looking for results that don't exist because the test was never ordered. At the time of collection, some of the possible errors could be a misidentification of the patient, your antiseptic's not dry, you used an expired tube, not inverting or mixing an anticoagulant tube properly, using the wrong tube, or drawing your tubes in the incorrect order. Mislabeling the tube with the wrong label, mixing your tubes too vigorously. If you shake the heck out of that tube, you can cause the blood cells to rupture inside the tube, and it will hemolyze the sample. Prolonged tourniquet application, anything more than 60 seconds, run the risk of causing something called hemoconcentration. Underfilling the tube can be especially important errors when working in coagulation studies, because you need a specific ratio of blood to anticoagulant. And if you don't have that, you're going to get invalid results or the wrong collection time. Some tests have to be done at a set interval. And if they're not tested and drawn at the right time, it's not giving the information that the medical team needs to take care of that patient. Errors that can occur during specimen transport is something like a delay in transport, especially on a time-sensitive specimen. One that will oftentimes be collected by the nursing team and then brought down to the laboratory is a test sample called a wet prep. You are frequently looking for things that are still alive and moving that were collected from a human body on a wet prep sample. If that sample is delayed, those organisms, potentially pathogenic in nature, can dry out and die and stop moving. And when you put it on the microscope, if they've died and they're not moving, you won't find them. So you could miss something that a person has as a pathogenic infection because of a delay in transport. Or improper transport conditions. If you're running something like a bilirubin test that needs to be protected from light, and they don't transport it in a light protecting container, or someone provides the wrong transportation temperature for a sample, it can destroy what you're looking for, and then you won't find it. It could be there in the patient, but because the sample was transported wrong, it's not there in the sample when you test for it. Errors that can occur during your specimen processing can be a delay in processing or testing, the improper processing of a sample. If someone allows the sample to evaporate, or if there's clots in a plasma specimen, if contamination from other specimens gets into that sample, or glove powder. A common contaminant doing microscopic analysis for crystals is the powder from someone's gloves who's either working at the microscope or was processing and preparing the specimen or collecting the sample. The starch powder from someone's gloves can actually look like a Maltese cross crystal underneath a polarized microscope. Now it's distinct in shape, so you see it, you know what it is, but it's a contaminant that's getting in the way of what you're actually looking for. You can also have issues with centrifugation, failure to separate the fluid from the cells, incomplete centrifugation, or incorrect centrifugation settings. Oftentimes you'll see failure to separate fluid from cells if somebody spins a tube down too early. If you've got a tube that's supposed to clot and it hasn't finished clotting yet, and someone centrifuges it anyways, you won't get a full separation of the fluid from the cells. Another error that can occur during specimen processing is mislabeling an aliquot. Again, mislabeling is the worst thing that you can do in the lab. Above and beyond running the wrong test, mislabeling is what hurts people. You also have to keep in mind time limits. All specimens should be transported to the lab without delay. You may have to repeatedly remind the other teams in the hospital that you work with of the importance of this requirement, because it is very inconvenient for a person to have to stop what they're doing and walk 5 to 15 minutes across the hospital to drop the sample off at the lab and then walk another 5 to 15 minutes back to where they were and continue their work. It adds 30 minutes of travel time, potentially, onto the process of getting that work done every time they have to bring a sample to the lab. Because of that, a lot of locations and teams will like to bring things down in a batch. They might collect a whole bucket of samples and bring them down at the end of the shift. Sometimes that's okay. Oftentimes that's not, and it depends on the work that needs to be done. According to CLSI, the Clinical Lab Standards Institute, serum or plasma should be physically separated from your cells as soon as possible, unless there's conclusive evidence that a longer contact time will not contribute to error in those results. They also state that separation of cells and plasma or serum should occur within a time limit that protects the stability of the analyte. They've set 2 hours as the max time limit for separating serum and plasma from the cells if you're testing something such as catecholamines, lactic acid, or RNA molecular testing. You also want to apply that 2-hour time limit for tests like glucose, ionized calcium, potassium, and others. Many laboratories, because of this guidance, are just going to set 2 hours as a blanket rule to cover everything when it comes to specimen separation. Regardless of the test you're performing, it is likely that your lab will just set as a policy everything has to be separated within 2 hours. Now, depending on your facility, this may not mean it has to be poured off of a gel separator tube, because some facilities will consider thixotropic gel in the tubes as a full separation of the cells and formed elements from the fluid component of the blood. Other facilities will still require that you pour it off within that time limit. I am going to note, however, that I have seen cases where a tube that was allowed to have the fluid sit on the thixotropic gel for several days had carryover of analytes, contamination of analytes from the formed elements diffusing through the gel into the fluid above the gel. Specifically, there were cases where that occurred with potassium that were investigated. So do keep in mind that thixotropic gel is not a perfect separation. If you need to store your samples, you always want to pour them off and don't just let them sit on gel. Prompt delivery and separation will minimize the effects of metabolic processes, such as glycolysis, unless those processes are chemically prevented, such as using sodium fluoride to inhibit glycolysis. Prompt delivery can be fairly easily achieved if you have an on-site laboratory. Many times the hospital or clinic will have an on-site laboratory, but not always. There are cases where you may be working at a lab and the lab is its own facility, and other facilities in the area will send a courier to bring samples to you periodically throughout the day. Getting samples on time with prompt delivery becomes even more important in those situations. Stat or medical emergency specimens will take priority over all other specimens. They're going to be transported, processed, and tested immediately. That means you will stop what you are doing and handle the stat or emergency work first. If you see medical emergency and you see stat may or may not indicate a life-threatening situation. Medical emergency will always indicate a life-threatening situation. So of those two, if you get notified of a medical emergency and you have a stat urine sample so that somebody else can go in for a routine surgery, you will prioritize the medical emergency. Coagulation specimens. The acceptable amount of time between coag specimen collection and testing is going to depend on the test. But typically, it is best practice to process and test them as soon as possible after collection. The blood cell metabolism is going to continue in your specimen after you collect it. Those cells are still going to be alive for a set period of time. It's going to depend on the temperature of the room you're in, the humidity, various factors like that. But they could be metabolizing analytes and altering the composition of the blood you're about to test, potentially for several hours after you draw that specimen out of the body. Chilling the specimen can slow down blood cell metabolism and prevent the destruction of thermolabile analytes. What that means is something you're looking for that is altered or destroyed by heat. Blood specimens that require chilling, such as ammonia, lactic acid, and gastrin, should be completely immersed, the tube will be completely immersed, in a slurry of crushed ice and water. Just cold water alone is not enough. Just ice alone is not enough. What you want to do is crush ice, pour water over that crushed ice, and then put the tube in a little biohazard bag so that the label on the tube doesn't get soaked and fall off, and submerge that whole setup underneath the level of the water that's in the ice. Large cubes or chunks of ice without water are not going to adequately cool that specimen. Contact with a solid piece of ice can also potentially freeze a part of the specimen, which can hemolyze your cells. The formation of ice crystals is physically destructive and can damage the blood, so you don't want to just put something on pure ice. Other specimens will require a warming block to keep them at about 37 degrees, because there are some tests that will be interfered with if your specimen cools down. If you have a light specimen test, your most common example being bilirubin, you want to transport it in something that will protect it from light. Whether that tube is wrapped entirely in tinfoil, which is a common option for labs that don't have specific tubes for this purpose, or you take a brown plastic glass or a brown plastic or a brown glass tube and use that to protect it from light. We call them amber tubes. Those can also protect bilirubin from light. If you do not do this, the level of bilirubin in your sample can go down by up to 50% within 1 hour of the time it's drawn. That effect is so powerful that little babies that are born with too much bilirubin are put under sun lamps like somebody's trying to grow a plant. But it's a baby, and they're put under those sun lamps so the light from the lamps can break down the bilirubin, because even the light through human skin is still strong enough to break it down. Some examples of the ones that you want to keep warm. Cold agglutinin testing, cryofibrinogen, and cryoglobulin testing. You want to keep those warm. The ones you want to protect from light. Bilirubin, beta-carotene, your A, B, and C vitamin testing. The samples that you want to chill in an ice slurry or a cooling rack. ACTH, ammonia, catecholamines, gastrin, homocysteine, lactic acid, PTH, pH and blood gas, pyruvate, and RNA testing. A suitable specimen is required to have an accurate lab result. If you don't have a suitable specimen, if someone brings you an unsuitable sample, either there's not enough of it, or it wasn't properly transported, or it was collected incorrectly, you have to reject the sample. And this is where lab techs and clinical teams often butt heads. They'll try and argue, oh, just try and run the test anyways. I know it's not right, but just try it. And this is where you have to stick up for your work and your professional ethics and tell them, no, I'm not going to accept this sample. I'm going to keep it. I'm going to quarantine it separately in a storage location. I'm going to mark it as rejected, and you're going to bring me another sample that is acceptable. You have to stick up for yourself in your lab to maintain the quality of work that your patients need to get proper treatment. Other causes of rejection, aside from the ones already spoken of, can include lipemia. If your sample is clotted for a coagulation or a plasma sample, or if you've got a hemolyzed sample, which is where your RBCs get destroyed, and you can see the hemoglobin will stain the plasma or the serum a reddish color. The worse the hemolysis, the darker red. The worst I've ever seen was on a person who was having in vivo, which means in the body, hemolysis of their blood. Their blood was literally falling apart inside their own body. I centrifuged the tube. I took the tube out of the centrifuge. I questioned myself, did I actually centrifuge this tube? I put it back in because I thought, I must not have hit the start button. I centrifuged it again, and I watched the whole run this time, pulled the tube out, and I couldn't tell that I had centrifuged the tube because the blood cells had released that much hemoglobin and iron into the fluid. I couldn't even tell where the fluid began and ended and where the cells began and ended. That's a bad day. That is a very bad day for somebody. Hemolysis will most often occur from using too small of a needle to collect a specimen, when someone mixes tubes too quickly or forcefully, they shake that tube instead of gently inverting the tube, or they're improperly filling the tubes. If somebody collects a big syringe full of blood and then they squeeze it out into the tubes that they've got sitting on the countertop real fast under a lot of pressure, that can also hemolyze the samples. This is another time where nurses and lab techs will tend to butt heads because it's not able to be known if a sample is hemolyzed or lipemic or clotted until you actually check. When you centrifuge that sample and you look for those things and find them, you then have to call the team that brought that sample to you and request another sample. Sometimes they get offended and try to blame you, saying it must have been your equipment that hemolyzed it. Centrifuges don't hemolyze samples, but phlebotomists do, and the phlebotomy procedure can. It is never the fault of your centrifuge for the hemolysis in a tube. The vast majority of the time, when it's not because of something going on in the patient's body, it's because of the collection technique. Lipemia is the term for when you have abnormally high levels of lipids or cholesterol or triglycerides, fats, in the blood. It'll make the plasma or serum look a milky, cloudy white color. When it gets cloudy and hard to see through, we call that turbid or turbidity. The cloudier it is, the more turbid it is. That's what that term means. This can get bad to the point where you can't see through the plasma anymore, and it looks like there's just milk on top of the blood cells after you centrifuge it down. That is especially likely to occur in some patients who have hereditary diseases that cause their triglyceride levels to be higher than normal. When setting up your centrifuge for these samples, keep in mind that this is a piece of equipment that is going to spin very, very fast. The rotor, the part of the centrifuge that holds your tubes and spins, is located in a sealed chamber in the middle of the centrifuge, and typically will not be able to be opened while it is moving. If for some reason you have old, outdated equipment that allows you to open it while that rotor moves, don't do that. Because if your rotor, which may weigh several pounds, is spinning at several thousand rotations per minute, and you stick your hand in there to try and stop it by hand, it can break your fingers or worse. If it's spinning fast enough, it can take your fingers clean off. Be careful with your centrifuge. That's why any modern centrifuge is going to automatically lock itself when it operates, and it will not unlock until it stops spinning. Typically, the carriers for holding the tubes will be attached to the rotors. As it spins, that spinning is going to create something called centrifugal force or centripetal force, depending on how you want to refer to it. It's going to create a force that's many times the standard of force of gravity, which will accelerate the rate that the sediment will fall out from floating in the whole blood to separate out into its base components. Instead of taking hours to separate, it can be completed within minutes. The faster the centrifuge speeds are set, and the larger the rotation swing of that centrifuge is, the faster this process will occur. When you set up a centrifuge, you need to properly balance it. This is not something that I can show you just with my voice. I will describe, however, that you want to have an equal amount of weight on each side of the centrifuge, and that if you have swinging buckets in your centrifuge, you want to balance the weight over the center of those swinging buckets, so that when the centrifuge spins, the buckets have an equal amount of weight on each side of their pivot point. Specimens for plasma that are collected for tubes that contain anticoagulants typically can be centrifuged immediately. You're not going to have to wait for them to clot because they're not supposed to clot. So oftentimes you'll get heparinized plasma instead of serum when you need to run a chemistry test that's stat. Or your facility may just do that as a routine policy to reduce turnaround times overall. Plasma separator tubes or other heparin-containing gel tubes are also available. to help maintain specimen stability. Your samples are going to be stable longer sitting on top of thixotropic gel than if the plasma or serum is just sitting on top of exposed red blood cells. You don't want to spin your serum samples down until they're completely clotted. Usually that'll take 30 to 60 minutes at room temperature. You can tell visibly if your sample's completely clotted because when it is, you'll see some of the cells separate from the plasma and serum. There'll be a thin serum or plasma layer on top of that clot, and you invert it, and it'll literally fall from one side of the tube to the other, like a big lump or chunk of cells. When you see that visible clot in the tube, it's ready to spin down. Now, if your patient is taking anticoagulants, it may take longer than normal for the tube to clot. On a side note, there are something called rapid serum tubes, which contain pro-clotting factors, like little silica particles, that can increase that reaction for the clotting cascade or the coagulation cascade. And instead of waiting 30 to 60 minutes, you might only wait 5 or 10 minutes for it to clot. Still takes longer than a plasma tube does, but it's significantly faster than not having those factors. An aliquot is the term for taking a portion of a specimen out of your main sample tube and transferring it into another separate container that you're going to use to transport around the lab to run your testing on. Your aliquot may be into a separate tube that you then seal and label, or it may be into a small cuvette or container designed to fit just neatly into a rack on a machine. The aliquot will still need to be labeled with the same patient ID. Aliquots of specimens are commonly created when multiple tests are ordered on a single specimen, or when tests are going to be performed on different instruments at the same time, or if different areas of the laboratory department all need to receive part of that sample for simultaneous testing. According to OSHA, all procedures involving blood or potentially infectious materials shall be performed in a manner such as to minimize splashing, spraying, splattering, and the generation of droplets of these substances. Because of that, disposable transfer pipettes should be used when transferring serum or plasma into an aliquot tube. You should be working behind a benchtop splash shield, and you shouldn't be pouring from one tube into another. You use a disposable transfer pipette to transfer into your aliquot. That will minimize the risk of a splash, spray, or splatter. When making your aliquots, you need to be careful to avoid mislabeling your samples. Especially if you're working with a large number of samples, it can be easy to lose track of where you're at. So you want to label as you go. Otherwise, you could be working on something. One of your coworkers could come up and ask you a question and distract you, and you look away and you go back to what you were doing, and then you accidentally put the aliquot into the wrong container. You have to be cognizant and aware of that possibility so that you set up your workflow in a way to minimize those risks. You also want to prevent mixing up plasma or serum specimens. Once you've spun it down and transferred into an aliquot tube, unless you label that tube as plasma or serum, there is not a way to just visually look at that sample and tell, because plasma and serum look identical to each other. Once you make that aliquot, you want to cover or cap that tube. Per CLSI, a serum or plasma aliquot can remain at room temp no longer than 8 hours. Typically, you're going to think of room temperature as about 20 to 25 degrees Celsius. If you want to think about 60 to 75 Fahrenheit, that's your standard room temperature. Refrigerated for up to 48 hours, which is between 2 to 8 Celsius, or frozen, lower than 20 degrees Celsius, for anything longer than 48 hours. It is not unusual for certain specimens to be stored, waiting to be analyzed in a batch or to be sent out altogether. It's the responsibility of each lab to determine their own specimen stability criteria for this process. To ensure the stability of your analytes while held, specific references should be consulted to determine the appropriate handling and storage conditions. That's where your bench supervisors are going to come in. They're going to pull scientific literature to use as a reference where people have already established how long these can be held for. And those references will be used to set your own laboratory's policy.